So good afternoon. This is Yvette Kelly with the Managed Care Technical Assistance Center, and I'd like to welcome you to today's Ambulatory System Infection Control for Downstate Providers webinar. Today's webinar will be led by our partners at the New York State Office of Mental Health. Before we get started, I just want to take a few minutes to review some housekeeping items. Please note that the slides and recording from today's presentation will be made available and posted to our website, mctac.org, within the next few days. So if you have a colleague who isn't able to join us today, or you'd like to review this content at a later date, you will be able to do so. Today's presentation will also conclude with a question and answer period, and so we are asking participants to please submit questions at any point during the webinar. Please utilize the chat box feature located on the right-hand side of your screen to submit your questions. When submitting questions, if you could please submit to all panelists using the drop-down menu, that will ensure that your question is visible for all of us to see. Our presenters will do their best to address these questions in the time permitted. For any technical difficulties, please chat to our host, who should be able to assist you. And with that, I am going to turn it over to Maura to get us started.
Hey, Moira, if you could take yourself off mute, that would be great.
That's great. So I just introduced myself, and I did it all on a practice run, obviously. So thank you. My name is Moira Tashian, and I am the Associate Commissioner here at the Office of Mental Health for Adult Services. And I want to thank you for joining us today. Thank you also for all the time you have spent serving individuals in very unique ways during this pandemic. We recognize and want to recognize all the challenges, both personally and professionally, you have been enduring over this period of time. And again, on behalf of our Commissioner Sullivan, thank you very much for all that you are doing. This afternoon, we wanted to have a conversation with you about the cluster system and the guidance and updated infectious control around how to proceed as we move forward in this period of pandemic. It is our hope that we'll be able to continue having dialogues with you in the coming weeks and months. But for now, we're looking forward to your questions, and we'll receive them at the end of our presentation. For now, I'm going to turn this over to Dr. Flavio Casoy, who's going to update us on infectious control. Dr. Casoy?
Hi, thank you, Moira, and thank you, Yvette, and the folks at McTac for this opportunity to give this update. But most importantly, thank you to all of you for really carrying the torch and keeping the population of New York healthy and surviving this really terrible time that we've all gone through. It's around 8 months now. Since we last gave these updates in March, we've learned so much. There's been so much new information that have come out that we thought that it would be helpful as we go into the winter to give everyone another update on what's been happening and be able to answer any questions that may be out there. So anything that we can do to help, hopefully we can do it during this session or afterwards. Okay, next slide. And one more. So just to start with the basics, and I know that most people who are watching, probably know a lot of this information already, but just to go over it to be thorough. So what are the symptoms of COVID-19, this terrible epidemic? So symptoms can appear anytime from 2 to 14 days after exposure. Unlikely that they'll appear before 2 days and unlikely that they'll appear after 14 days. So that's a pretty good window. We might see, but not necessarily, right? But these are possible symptoms. Fevers of 100 degrees or greater. Sort of subjective symptoms of fever. That can be malaise or fatigue or muscle aches or chills. Often there's respiratory symptoms such as sore throats, coughs, or shortness of breath, difficulty breathing. And then less common symptoms include a runny nose, a headache, nausea or vomiting, diarrhea, and the much discussed loss of taste or smell, which is very distressing for people. There are also other atypical symptoms, but these are the ones that we see most commonly. Next slide. All right. So how is COVID-19 transmitted? So COVID-19 is spread primarily through respiratory droplets, and those are formed by sneezing or coughing or yelling or singing, laughing, talking, so forth. Any time you open your mouth, you can produce these droplets. In enclosed, unventilated spaces such as cars, closed offices, and so on, the above activities can also lead for the virus to become aerosolized. So in droplets, you have these little drops that fly through the air and land on surfaces, on people. But when the virus is aerosolized, the air actually becomes saturated, and it can just sort of live in the air, and that significantly increases the risk of transmission. One thing that we didn't know in the beginning, but now we know, is that it's possible for people to be infected with COVID-19, infectious, and be asymptomatic. So they don't feel sick and are moving around the world and exposing others to the infection. And this has been the main challenge, I think, in this epidemic. COVID-19 can also temporarily, quote unquote, survive on surfaces. This is not the main way of transmission. The main way of transmission is through the air, but it's possible for someone to sneeze or cough on a surface, someone else come by, touch that surface, and then touch their nose and mouth, and therefore get infected with the virus. Next slide. So the size of the droplet matters. I don't know if folks have seen this great picture, but the smaller the droplet in which the virus survives, the further it can move. This is why measles is such an infectious disease and is so easily spread. When someone who's infected with measles coughs or sneezes, these teeny droplets carrying the virus goes far and wide. Ebola, on the other hand, needs much larger drops to survive. So it's much less infectious and it stays closer to the person who's infected. Where does COVID-19 live? Well, somewhere between. In the United States, we have surmised that it's about 6 feet away is a good physical distancing. Other countries have said 2 meters, which is a little bit longer than 6 feet. But more or less, about 6 feet will keep individuals far enough away from getting hit by these droplets. And how big are these droplets that we're talking about? These are teeny tiny little droplets. So it's possible for, so when you look at the width of a hair that you pull from your head, right, that's about 125 micrometers or microns in diameter. These little droplets that sort of come through the air and land on people are 5 to 10 microns, and when the virus is aerosolized, it's even smaller. It's smaller than 5 microns. That's microscopic. So it's very difficult to watch these drops, and that's why it's so important to take these measures to protect ourselves from infection. Next slide. Okay, so how do we prevent? So the goal here is to slow the spread as much as possible. And you see here a picture of the cross-section of a face. And the secretions of where the virus lives is coming from the back of the throat, what we call the pharynx. That's usually where you feel a sore throat. That's where the virus usually hits first. So when you wear a mask covering the nose and the mouth, it creates a physical barrier between your pharynx and the world and the world and your pharynx. So if you're sick and asymptomatic, or maybe you have symptoms and you're wearing a mask, you will protect the world from your infectiousness. If you are healthy and walking about doing your job and you're wearing a mask, it'll put a physical barrier between you and whatever other sort of infectious people are out there in your environment. So a mask that covers the nose and the mouth is super important. And I want to emphasize it's important to cover the nose and the mouth and not just the mouth, because as you see in this picture, on the back of the throat, the nose and the mouth are connected. So if you just cover your mouth, it's almost as if you're not wearing a mask. So it's really important to cover both. Physical distancing, again, protects you from those droplets landing on you or your infectious droplets landing on other people. Reducing time indoors or increasing ventilation helps prevent those droplets from sort of surviving in the air, saturating the air where, you can breathe them in around the mask. So the more ventilation that you have or being outdoors, the better. Of course, it's harder in the winter. Rigorous hand hygiene and not touching your face helps prevent you from getting sick after touching a contaminated surface. So always wash your hands or always use the 60% alcohol gel. And it's really important this year, it's always really important, but this year more than others, to get your flu vaccine because influenza often looks like COVID. It's hard to distinguish which one you have, and you don't want to sort of have to deal with the fear of having COVID if you don't. And you can also become infected with both influenza and COVID. And the flu makes you at a higher risk of bad outcomes if you develop COVID also. So getting that flu vaccine, protecting yourself from that infection that we can protect ourselves from is super important, especially as we all wait for the COVID vaccine to become available. Next slide. Okay, so infection control. So we highly recommend for everyone to review the guidance on the OMH website. They have been updated. The last version came out on November 12th. It's super long, but it's super detailed. Lots of answers there. We're taking some of the information from that guidance to present in this webinar, but there's a lot of good stuff there. So highly recommend for everyone to read it. And then if anyone has questions, please follow up with questions, by email to your field offices or to us directly. Make sure that you educate your clients and your staff on the importance of physical distancing, on masks, on hand and face hygiene. The Department of Health has these great posters that you can post in your sort of facilities, so people are always reminded of the importance of staying safe. Highly recommend to just disinfect daily, frequently touch surfaces. There's a list of recommended products for disinfection. These are widely available, but also the virus on surfaces is actually pretty fragile. So cleaning with the common products that you have in your facilities is good also. To be optimal, you can see the products that are listed in the guidance, but just cleaning more often with the products that you have is also a very, very good idea. Make sure that you teach your clients and your staff to quickly report symptoms and to follow the guidance on quarantine and isolation. The most important thing is to protect, if people become sick, to protect others from getting sick, because this can spread really fast, especially because there's asymptomatic transmission. If you are in your facility, in your physical plant, change things around, change furniture around to promote that physical distancing, and remind everyone to get those flu vaccines because they're really critical. Next slide. Okay, so we know for mental health agencies, these last few months have been very difficult in terms of staffing. At baseline, even without COVID, staffing is difficult. But now with folks getting sick and these advisories, it's even more difficult. This is all taken directly from the mental health, the infection control manual that's on the website. If programs are experiencing significant staffing shortages and have exhausted other staffing solutions, it's okay for your staff who have been exposed to individuals with known or suspected COVID to keep coming to work, provided they take very significant measures. You don't want them to be symptomatic, so they have to be asymptomatic. They have to sort of be sure to follow all the infection control procedures, wearing masks, taking their temperature twice a day, preferably avoid working with patients who are at higher risk for complications. When they're not at work, to make sure that they are quarantining themselves and protecting their communities. And as much as possible, always maintain that 6 feet of distance. And if at any point your staff develop any symptoms consistent with COVID-19, they should go home. And you should encourage them to get a test. And all this is described in great detail in the manual. So take a look, and we're happy to answer any questions about this in the question and answer period. Next slide. So New York State has introduced the COVID-19 microcluster strategy, and I think everyone has probably heard about this in the news. Here is a picture of a map that you might find on the New York Forward website. Here you see a yellow precautionary zone and an orange warning zone. There's no red zone here in this particular picture. But the different zones have different degrees of precautions and rules about infection control. And, much of the state has sort of these different microclusters with the aim of reducing the spread of COVID. So take a look at the microcluster website and to see if your particular programs are in any of these zones. We have you can go to the next slide. We have developed guidance of when programs should take enhanced infection control precautions, and we'll go into what those are for ambulatory programs. As always, whether or not you are in a zone, programs should implement all of the infection control measures that we've discussed so far. But for programs who are in a red or an orange zone, programs that have had a cluster of 2 or more cases in clients or staff, if programs receive a recommendation from their local health department or Office of Mental Health to take these enhanced precautions, it's really important that programs do, and that these enhanced precautions be kept for 2 weeks, after the conditions are no longer met. And the reason we say 2 weeks is 1, to help programs with scheduling, and 2, to make sure that people who may be asymptomatic carriers, have cycled through, and there's no sort of hidden possible new clusters that are coming out. So keep an eye out to see if any programs in your agency has to undertake enhanced precautions. Next slide. Just a reminder that, again, programs should tell their staff to always wear a mask covering their nose and their mouth while on shift, unless they're alone in their own office. Always wear a mask when interacting with the client, and if any staff share an office or is in a conference room or in a lunchroom or something like that, a mask is required. If you can see another person, you should be wearing a mask, even if you can keep that 6 feet physical distancing. There was a recent guidance that came out for a recommendation that any staff who interact with clients, to also wear a face shield. And this guidance just came out from the Department of Health, and we recognize that this is very difficult for many programs to implement. So if you have the availability of giving your staff a face shield that covers their eyes, that is the recommendation. If you don't, I would double down on the mask, on the physical distancing, on the hand hygiene, because those are the most important measures you can take. The face shield is to protect, that errant droplet that might land in someone's eye. But if you can keep that physical distancing, if you can do all the other things that are necessary to keep people safe, that will be very helpful in reducing the transmission. Next slide. So you can find out information about testing on the Department of Health website. Testing is much more available now than it was in the beginning. The results are coming back much faster, not as fast as we would like, but much faster than before. The best test is what's called the diagnostic PCR test. That you can be pretty certain that the results of those tests, whether positive or negative, are accurate. So you can find information about that on the Department of Health website. There's also rapid tests that are being offered in all sorts of different places, pharmacies, primary care offices. A rapid antigen test that's positive should be confirmed with a PCR test. A negative test should just be repeated pretty frequently. The best tests are the PCR tests, but that doesn't mean you shouldn't be taking the other tests if those are available to you. So the more testing, the better. But remember to, we recommend confirming the positive rapid tests with a PCR test. Next slide. Okay, so just to get into some specifics for outpatient programs, that was general for all programs. So next slide. So programming, just in general, make sure that you educate your clients about COVID precautions, throughout all the different encounters, whether it's a psychiatrist or a psychologist or a social worker, and help clients maintain vigilance. We're all tired of COVID. We're all, wishing that we can, not wear a mask or, relax. But now, as everyone is going back indoors, now is the time to really push back on that COVID fatigue. Because this could be a very dangerous time for folks. Ahead of the session, call the client if they have a phone available to them. Screen clients by phone. Ask if they're having COVID symptoms. Ask if they have a thermometer at home and they can check their temperature. If they do, and you can prevent the possible exposure of folks at your program from someone who's sick, that would be, very beneficial. When clients come to your facilities and they don't have a mask, offer them one. Encourage clients to wait outside, or create physical controls in the building to promote distancing. Don't forget about bathrooms, elevators, and so on. If possible, encourage clients to come unaccompanied, alone. That will decrease the density of people waiting in your facility. Get rid of all the magazines, the toys, and other frequent contact objects that you'd have to be cleaning or that are difficult to clean to prevent the risk of that contact transmission. Remember to protect your receptionist and other sort of front door staff. A plexiglass shield is a good approach. It'll protect them from those flying droplets. If possible, keep doors propped open and windows open to maximize ventilation. That will reduce the risk of that aerosolization. Of course, it's not very energy efficient. It might get cold, but it's worth it. It's worth it having a little bit of a drafty indoors to reduce that risk of aerosolization. Next slide. Okay, so if programs offer groups, when you're in a standard precaution situation, kind of regular every day, not in a specific cluster, your group should have no more than 10 participants, including the leaders or any other staff, so no more than 10 people participating. Ideally, in a well-ventilated room, and it's important that everyone can maintain at least 6 feet distance from everyone else. Everyone must correctly be wearing a mask, covering their mouths and nose. If the room doesn't fit 10 people, that's physically distanced, you got to reduce the size of the group and keep the group short, no more than 1 hour, and let the room air out in between groups. So give it some time for there to be air circulation so groups aren't breathing each other's air. For individual sessions, everyone needs to wear a mask and maintain that 6 feet physical distancing. You might have to rearrange the furniture in the offices to allow for that to happen. Okay, next slide. So we encourage the use of video or telephonic care as much as possible. Now, of course, it's important to make that deliberate decision on a client-by-client basis on who is appropriate for telehealth care. Some people need in-person care, and some people are going to be okay with entirely virtual care, and some people are going to, may benefit from a combination. So that has to be determined on a person-by-person basis. By the clinical treatment team, and of course the client. But you have to maintain capacity for in-person visits. But as much as possible, reduce density. This is difficult. This is very difficult to do, and our physical plants are not designed, for this type of interaction. But the best you can to reduce that density will be very helpful in reducing the transmission rate. Programs such as ACT or Mobile Crisis or the different forensic transition programs, who specialize in these sort of more vulnerable individuals who are high risk and are not able to engage in typical outpatient services, have to have a higher level of caution in shifting to telehealth. In areas that aren't designated as the red microcluster zones where there is a sort of more serious outbreak, these programs should try to focus on having in-person visits, whether at your facilities or in the client's home or in the community. And for as many clients as possible, because we're worried about these clients becoming disengaged and having sort of bad things happen. We saw sort of several bad outcomes happen earlier in the year for folks who had been enrolled and kind of like fell out of care as folks who were adjusting to the pandemic realities. Now, what makes it very complicated, of course, is that these individuals often have the medical problems that make them quite high risk for COVID infections, right? So it's important that, the teams really think about on a case-by-case basis all the risks and benefits of all the options and make a determination, even though nothing, there's no best, right? There's only least worst in this pandemic situation. Next slide. Okay, so thinking about what to consider in terms of in-person versus telehealth. So infection control, first and foremost. Has this client traveled to a place on the Department of Health travel advisory? If so, have they been tested? Are they supposed to be in isolation or quarantine? Does the client have symptoms? Or have they come into close contact with anyone with symptoms? Is your physical plant arranged in such a way that you can limit density and maintain physical distancing? Some of the city-based programs or urban-based programs might not have that physical plant or that ability, so that has to be taken into consideration. What's your PPE stock like? Do you have masks? So that has to be taken into consideration. Does the client have medical comorbidities that puts them at risk for worse outcomes if they become sick? how do they get to and from the program? Do they take public transportation? What are those risks? And are there any individuals with significant risk factors who are living in the household with the client? So it may be that your client might be young and healthy, but that person is living with a parent who has serious lung disease. So how do you weigh those risks? So things to consider. Next slide. Thinking about how appropriate the client is for telehealth. Do they have the cognitive or developmental capacity? Can they engage in remote care, and can they use the different technologies? Do they have access to the technologies? Do they have a phone? Do they have minutes? Do they have a space that's private? Do they have broadband access? So this has to be assessed and taken into consideration. Is in their household, are they going to be able to speak about the different topics that are important for them to talk about in therapy in a way that's safe? So, for example, if you have transgender clients, or lesbian and gay clients who are not out to their families, can they have that conversation? So that's something to think about. Thinking about what are the circumstances when there's the situation changes, and the person needs to come in for in-person services instead of virtual services, and thinking about having that conversation with the client. So there's agreement up on this frame. In the case of a child, what's the ability of the parent or caregiver to do all these things? Can the parent or caregiver supervise and help the child to make sure that safety is maintained during the sessions? Do the different technology platforms that are available to the clinic, what's the impact on the rapport and communication with the client? And virtual client requires virtual care in some ways require a more active participation than in-person contacts, so that the clinicians can see different, see the patient well. So you don't have a camera pointing at the ceiling, for example. And is the client able to do these things to be able to adequately engage in care? Next slide. So other factors to consider. Are there aspects of the care that require in-person contacts? For example, long-acting antipsychotic injections, or the need for serial physical exams, or the need for laboratory specimen collection. What's the strength of the relationship between the clinician and the client? How engaged is the client? Is the client new to the program? Is there a recent change in clinician assignment? All these factors can impact whether or not telehealth is successful. Thinking about the modifiable and non-modifiable risk factors. For example, what's the risk for suicide or other self-harming behavior? Risk for violence, housing instability. With the economic recession that we face, a lot of folks are really struggling in terms of their housing. Impact of substance use. We've seen an increase in overdoses. Are they coming back from incarceration? Has there been an increase in the frequency of CPAP or hospital admissions? So thinking about overall the risk of the client and how much can they be held via virtual sessions. Sort of thinking about how, is the client able to remotely implement safety plans? And if you are implementing a specific clinical approach or evidence-based practice, can it be successfully implemented by telehealth? For example, if you're a psychologist and you want to do some sort of neuropsychological test, can you do it via telehealth? Sort of thinking about that approach also and making these considerations. Next slide. And then, of course, there's system factors. Is the individual shifting care between systems or between programs? How do you avoid people falling through the cracks and avoid disruptions in the care? In some ways, telehealth may be better than in-person because the barrier of activation is lower. The person is presumably in their home. So that's a consideration. For individuals who are coming back from prison or other forensic settings, it's strongly recommended that there be an in-person warm handoff on the day of release so that the person successfully gets from the jail or prison to their housing program, are able to access their medications, food, clothing, being able to get a telephone for telehealth contacts. And this is a moment when people fall through the cracks. And that in-person contact is really important to help the person, welcome the person back in the community, help them adjust and figure out how to sort of survive independently. Also thinking about the geographic distance to the nearest emergency room, and thinking about what the patient support system is like and their current medical status. So if you need a crisis response, how easy is it to get if the person is on telehealth? All important considerations. Next slide. Okay, so we spoke about standard infection control precautions, and we spoke about considerations for when to do telehealth, when to do in-person care. Things to change when you are in one of those cluster zones, or if your program has an outbreak, or if your local health department says, be extra cautious here. Stop indoor groups. If you are able to hold outdoor groups, in the winter, if you have those hardy souls, go for it. But if you are under enhanced precautions, no longer do indoor groups. It's just not worth the risk. If you can, equip your staff with a face shield or goggles, in addition to a mask for those in-person individual visits. It's recommended that happen. But we know that programs, are going to have difficulty accessing those face shields. And you should consider special appointment blocks for elderly or other high-risk individuals so that they only come to the facility in times when other individuals are not around, and that reduces their exposure. So something to consider and implement, though, of course, that has its own challenges. Next slide. I think that might be the last one. So, okay, so I've spoken.
The slides.
Yep. Okay. So I've spoken for a long time. Let's break for questions, and if there's anything that I glossed over that you want to ask about, please do. Happy to answer them.
Yeah. Yeah, thank you, Dr. Crisoli, for that very informative presentation. As we move to the Q&A portion of today's webinar, just a reminder that the slides and recording from today's presentation will be made available and posted to our website shortly after today, usually within a couple of days. So, if you check back, you should be able to find it there. And also, if you have any questions, please submit your questions via the chat box feature. We have received a few questions, and so I'll just start with the first question. And it was, Dr. Crisoli, can you speak more about the aerosolization process? So if it is aerosolized, is the distance of 6 feet still preventative, or once aerosolized, does it travel further?
That's an excellent question. So think about this as like a smell, right? So if you light one of those aromatic candles, that smell permeates the space, and it kind of just stays in the space for a while, even after you blow out the candle. So the way to make that smell go away is by airing out the room. So when the droplets become aerosolized, they just kind of hang out until it gets aired out. And then 6 feet becomes a lot less protective. and especially if the space becomes saturated. So if you're seeing someone in a small closed office, or if you're riding with someone in a car that's closed, the air can saturate with these particles, and then you'll be breathing in this air from behind your mask and so forth. So it's a risk of spread. That's why we emphasize keep the space ventilated. Make sure that there's air coming in and leaving that space to prevent the aerosolization. Because once it's there, it'll just kind of stay there until it gets sort of blown out. That's kind of how we're seeing so many hospital staff becoming infected in the ICU. Before we really realized this and sort of changed the settings in those sort of ICU rooms to increase ventilation, despite all that PPE, staff were getting exposed. So in the hallway, outside the ICUs and so forth. So that's really strongly encourage making sure that there's ventilation in the spaces if you're seeing someone indoors.
Thank you. We do have a few other questions. One of the questions is related to COVID being able to temporarily survive on surfaces. And so the question is deep cleaning of surfaces necessary and productive when there is a confirmed case of COVID? Or since the virus on surfaces is fragile, is regular cleaning enough?
We recommend using the products on on the list that's available on the infection control manual, and there's a long list, and most sort of common cleaners are on there. So make sure that what your facility is using is on there. If for whatever reason you don't have those products, don't stop cleaning. Keep cleaning. Clean more often, and make sure that there's soap involved. The optimal is to use sort of those products on that EPA list, Environmental Protection Agency list. But if you don't have that, make sure you keep cleaning and clean more often. You want to scrub those surfaces, with soap water. That's better than nothing. The optimal is to use those products, but if you don't have it, make sure you keep cleaning the surfaces. And most importantly, emphasize hand washing, not touching your face, and so forth. That, this gets spread when you touch an infected surface and then you touch your eye or your nose or your mouth. So if you stop touching your face and if you, wash your hand a lot, that will reduce that risk dramatically.
Thank you. We do have a few questions regarding testing. And so the question is, can you speak more about PCR versus rapid testing and when PCR is required and when is rapid testing acceptable?
Okay, so the PCR test is that test that requires that long swab in your nose. But there are some companies that are coming out with more comfortable specimen collections, and those usually require the sample to be sent to a lab where there's skilled technicians to run the test, and those take a few days to a week to come back. Usually. Sometimes they come back the next day. That's really good. The rapid tests don't have to be sent out to the lab, and there's a whole bunch of different types. On the whole, the rapid tests are less definitive than the PCR tests, but they give you immediate information. So if you have a rapid test and it comes back positive, you should go into isolation, go into quarantine, and get a confirmation PCR test. Because what it does is it lets you take precautions before that lengthy test comes back, and that keeps folks safe. A negative rapid test is partially reassuring. It's not fully reassuring. But it does help give some information on the population level as to how dense the virus is. So we want the more testing we have, the more we know, the more precautions we can take. For the individual level, the rapid test, is less informative than the PCR, but it does give some information. If you have a negative rapid test, my recommendation is to repeat it, after a couple weeks, 3 weeks, if you're not symptomatic, not around anyone who's sick. If you're in a place that has folks who are sick, repeat it after a couple of days if you have access to it. The best is the PCR. If that's not available, the rapid antigen test is good information to have, but it might not be the most accurate. But it's still enough to help you take actions that will keep people safe.
Thanks. And just to piggyback on that question, there's another question regarding the time frame for testing. So someone says they've heard guidance that people should get tested once a month. Is that true?
Well, it depends. As everything else in this, right, it depends. Okay, so for the PCR, you don't want to be tested too early before there's enough virus to be picked up. Rule of thumb is 4 to 5 days after when you think the exposure might have been. That will maximize the chances that a positive is true and a negative is true. The PCR might stay positive even after you're no longer sick and no longer infectious, because it's picking up these teeny tiny little pieces of RNA. And it's very sensitive, so that's good. So it's once it's there, it's very informative. The rapid test, the rapid antigen test, is most accurate when there are symptoms early in the infection. So if you have a sore throat, or if you have a runny nose, or if you have what you suspect might be a symptom, that's a great time to get tested. If you're around other people who are sick and you get tested and it comes back negative, that's reassuring. If you get a positive rapid test, you should get a follow-up PCR test just to confirm. If you're in a place that has it's a yellow or orange or red zone, you getting more frequent testing is helpful. If you're in a place where there isn't very much infection, if you're way in North Country or in a place that's where you're not having very much contact with individuals, more testing might not be more helpful if you're not being exposed to people with COVID, because there is a certain proportion of tests that are false positives. And when there's fewer true positives, it becomes harder to distinguish, what's true and what's false in those tests. So if you're in a place where that has a lot of COVID, that you have a lot of exposure, more tests are good. If you're not getting exposed, if you're in a place that has low community transmission, do the precautions, and it's not necessarily true that you need to get tested super often if you don't have a reason to. Unless there's a particular public health guidance in your area for everyone to get tested or to get more tested, it's okay not to go and get that test. In terms of timing, I was going to say also, if you test positive on the PCR test, you're never symptomatic, you never develop symptoms, and you do the 14 days of isolation, and you're done, and you've gone through your period, and then you get tested again, it might still be positive. In which case, you don't have to redo necessarily that isolation period. You should call a healthcare provider to double check, because it might be a residual positive test. So if you get a positive test and you do the isolation, you don't necessarily have to get tested again. You might come back positive again.
Thank you. There is a question around masks and understanding the difference between cloth mask and surgical mask for staff and clients, and what's more important. Is it more important that the mask fit well or that it's surgical? And so that's the question that they're asking.
Well, the surgical mask has the surgical mask has a little wire along the ridge of the nose that helps you fit it to your face. So the surgical mask is, in some senses, safer than the cloth mask because it's built for this purpose. However, a good cloth mask it makes you much safer. So if you can give everyone a surgical mask, and make sure that they change it, and that's better. But that's not necessary. It's perfectly fine to have everyone wear a cloth mask. Now, what you don't want is these sheer silky masks or these sort of gaiters that you can feel someone's hot air through, that you see people running in pre-COVID times. You want something that is a little bit hefty that can catch those droplets. So something thin and sheer or knit, with lots of holes is not going to cut it. But a good sort of, thick cloth mask is perfectly good, provided that it's covering your face and your nose and your mouth.
Great, thank you. There's a question to clarify around the wearing of masks when sharing office with other colleagues. So is it required that all staff who share an office, despite 6 feet or more distance, wear a mask at all time, even if they're not moving about the office?
Yeah, that's my recommendation. If you're going to be in a room with other people, whether it's a shared office or a conference room for rounds or you name it, you should be wearing a mask that's covering your nose and your mouth. That's a physical barrier from the infectiousness in your throat to everyone else getting sick. And it's a physical barrier from whatever other asymptomatic folks are out there who are coughing and sneezing, getting to the back of your throat. So it's just extra safety, and what we're talking about, right, is probabilistic. What we want, if we can reduce the spread to less than one sick person infects one other person, then COVID is going to die out. It's going to sort of the numbers are going to go back down. So the more that you're wearing the mask, the more that you're doing to reduce the probability of more people getting sick. And that will keep everyone safer, you included. So if you're sharing an office, highly recommend it that your nose and your mouth is covered the whole time that someone else is there. The best would be if you can crack a window or, increase the ventilation in that room also, because then that reduces the risk of aerosolization. But definitely keep that barrier between the world and you, and that will keep everyone safer.
Thanks. A couple questions just around, if agencies are experiencing staffing shortages, and a staff person reports an exposure, is there a recommendation for testing prior to their return if they're not going to do the entire 14-day isolation period?
So if you are experiencing a staffing shortage and you have someone who's exposed, but they are asymptomatic, and they're checking their temperature twice a day, and they're following, all the precautions, and they're quarantining while they're not at work, they can keep coming to work. If they can get that test, that's even better. Because if they get the test and it turns out it's positive, then they stop coming to work and they keep everyone else from getting sick. If it's negative, well, that's reassuring. And they still got to come in and still wear the mask and, hopefully still take their temperature, but at least everyone's stress level is down. So, if you're worried about an exposure, you should get tested. preferably 4 to 5 days after that exposure. And if it's positive, don't come to work. If it's negative, that's good. If for whatever reason testing is not available, and it should be available almost everywhere in the state now, wear that mask, temperature twice a day, be very careful about sort of observing all, precautions, and you can still keep coming to work.
Excellent. We have time for just a couple more questions. On your last slide, you indicated that that certain enhanced precautions should happen depending on what color zone folks are in. So the question is, what color zone under the enhanced precautions would warrant no indoor groups?
Orange and yellow. Sorry, red and orange. I said that wrong. Red and orange, not yellow. Red and orange. If the Office of Mental Health, us or your local health department says take the extra precautions, or if you know that there is a cluster of 2 or more cases among your clients or your staff, just go into enhanced precautions for those 2 weeks. So definitely red and orange, but also in these other situations, your local health department, OMH, or if you have a cluster. If you yourself have a cluster, there's a risk that there's asymptomatic spreaders, in your staff or in your clients. So you want to reduce that human contact as much as possible. You don't want to sort of deny people, access to their injectables, but you want to be safer and take those enhanced precautions.
Thank you. And there's just a question around creating ventilation in small offices when there's no working window. So would you recommend that they leave the door open at the end of the night, or what would be sufficient in terms of creating some ventilation where there might not be access to the outside?
Well, I guess it's what can you do, right? Like you should do anything that's doable. So, air out the space in between clients. Leave that door open for sure. Maybe get a fan that can point out into the hallway. So that in between clients or at the end of the night, you have that air circulation. This is very difficult for clinicians to do, but if your agency administration can be in touch with the landlord to see if they can increase, whatever settings they have with their air conditioning or heating or whatever, that's good. But, that's very difficult for, programs that rent space in these commercial buildings. But anything that you can do to increase ventilation, however creatively, you should do it. If you're in an office that's like really stuffy, where there is no way to increase ventilation, maybe that office needs to become something else for a while and a different workspace be identified if that's possible. It may be that it has to be, someone who doesn't see clients can use that office and a different office can be used for client work. And though it's difficult, and every facility, every program is going to have to come up with their own creative solutions. But there's no good, right? Nothing good can, we're trying to avoid a terrible situation. So, there's no optimal. It's just doing anything that you can do to increase that circulation is what everyone should be doing.
Thank you. So I think we are running short on time, so I do want to just thank our presenters for sharing this information with us today. It's very informative. Also, just to let folks know, remind folks that we will post the slides and recording within the next couple of days to our website, so you will be able to access the material there. Also, we have received a number of questions that unfortunately we were not able to answer, but we will forward these along to the Office of Mental Health so that they can understand what types of questions are being asked. And with that, I just again want to thank you for joining us and appreciate all your time. So stay well and have a great rest of your day.
Thank you, Yvette. And I just want to mention real quickly, someone did ask, will there be a residential component of this? On Thursday, there'll be 2 sessions for residential. Thank you.
Thank you all.